Perfect. So thank you everyone who has turned up to take time out of your evening to talk everything about TXA. Um, as you may know, we've got Professor Ian Roberts here who probably would agree if I introduce him as Mr. TXA. He's involved in studies all around the world, but I'm sure he'll do an introduction himself. We're just going to talk about everything TXA and also make it as interactive as you want as we go through. Ian takes you through the learning material. If you've got any questions at all, drop them in the chat and there'll be plenty of time to get those questions put forward and get the answer from the expert. If there's anything you want to know about TXA, now is your time to do so. I guess I'll pass over to you now, Ian.
All right. Thank you, Ryan. And thanks all of you for coming to listen to TXA at the late o'clock, 8 o'clock at night. Right, I'm going to just share my screen and uh, share. So I think you should be able to see my screen now, and that's my first slide. So thank you to Matt and Ryan for inviting me to do this medical lounge thing on tranexamic acid. And I'm going to particularly talk about intramuscular tranexamic acid. So, because I think this is the big new thing in pre-hospital care. So this is, I know people are coming from different countries, but this was a big deal in the UK. This was the Manchester Arena bombing, a pop concert filled with young people and children, and some guy blew himself up, and there was lots of bleeding and injured people everywhere. I think hundreds and hundreds. 32 people died, and you've got a hall of people who have sudden onset acute bleeding. What's happening to them? Well, obviously, well, not surprisingly, their bodies are trying to they're trying to clot. They're trying to they've got ruptured blood vessels. The blood is falling out, and then there's this process of coagulation that's trying to stop the bleeding. Now, and this electron micrograph shows a blood clot, and it's basically the yellow stuff is fibrin, and that kind of knits together like a sort of a sieve, really, and all the cells get caught in the sieve, and this turns into this big, gelatinous lump, and that's a blood clot. But there is an enzyme in the blood called plasmin, and what this enzyme does, it's like a scissors, and it just cuts up those fibrin strands. So the body's trying to clot, but at the same time, there's this kind of unclotting mechanism going on called fibrinolysis. And you can see it here. This is the kind of molecular biology of fibrinolysis. Now, I'm not going to go into it in a big detail, but basically, when a blood vessel is cut or ruptured, it releases this stuff called tissue plasminogen activator. And it does what it says on the label. It activates plasminogen into this enzyme plasmin, this scissors. And then plasmin goes up after injury and starts chopping up the blood clot. And D-dimers are these little bits of the blood clot. So it's like you've taken the scissors to this spaghetti of fibrin, and there's little bits of spaghetti everywhere. They're called D-dimers. And you can see that that happens really early. So this is happening within 30 minutes of the injury. And so within 30 minutes of injury, this tissue plasminogen activator is released, and it's chopping up that blood clot just at the time when you don't need it to be doing so. A little bit later on, the body has its own kind of inhibitor of fibrinolysis, and that kicks in, but it kicks in late. So you've got this period of time early after the initial injury, where the body's trying to form a clot, but it can't because the fibrinolytic process is going on. So that's a little bit complicated. So at one stage, my nephew is an animator, and I said, can you help me make a video that kind of explains fibrinolysis in an easier to remember way. And so we made this together, and it turned out to be quite popular, and it won a science animation prize. So I'll just show it to you. You should be able to hear the sound. It's only a few minutes.
When a blood vessel is ruptured and starts bleeding, the body responds by forming long strands of a tough yellow protein called fibrin that traps blood cells and plugs the leak. This is called clotting. However, at the same time, it triggers another process which is not always helpful. It begins with these playful canines called plasminogen, but they won't be playful for long. The torn blood vessel has released tissue plasminogen activator, or TPA as he likes to call himself, and he loves causing trouble. Once TPA shows up, the plasminogen dogs get nasty. These hounds of hell are plasmin. The plasmin dogs tear fibrin apart, making the bleeding much worse. Of course, plasminogen activator inhibitor 1, or PI1 for short, could put a stop to all this destruction if she wakes up. And when PI1 does wake up, it's often too late. That's why we give tranexamic acid as soon as possible after bleeding starts. Tranexamic acid stops plasminogen binding to fibrin, sparing the clot from the plasmin dogs. And a nice blood clot can stop the bleeding.
So, oops, how do I get out of this? Next slide, page down. That one. Okay. Oh, no, that one. That one. So that's the molecular biology of fibrinolysis. So for some reason, as soon as you start bleeding, you've got this fibrinolytic process. And this drug, tranexamic acid, it stops these plasmin dogs binding to fibrin. So it's sort of, so you've got to get it in early, and because the process starts early. Now, we did a big trial of tranexamic acid in bleeding trauma patients called the CRASH-4 trial. We randomized 20,000 bleeding trauma patients to get tranexamic acid or placebo, and these are the results. So first, if you give tranexamic acid in the first hour, this is the ratio of deaths in the tranexamic acid group with the placebo group. If the ratio is 1, it's the same number in both groups, which it clearly isn't. It's less in the TXA group, and it's 6.68. So that's like a sort of, a 32% reduction in death due to bleeding. And that's big, and it's highly statistically significant. If you give it later, it's also dramatically effective, about a 20% reduction in death due to bleeding, also statistically significant. But the benefit gets less as you go later and later. So when we got this result, we just thought, wow, that's an amazing result, and it's going to be really important for patients. But the next result was really good news as well, which is whenever you've got a drug that helps bleeding, there's always a risk that it causes unwanted clotting. And in this big trial, there was no increase in unwanted clotting. In fact, there was a slight decrease in unwanted clotting. So, you know, there were fewer thromboembolic events in those who got tranexamic acid. So this is good. You know, we've got a safe and effective treatment for life-threatening bleeding, but it has to be given early. And, you know, overall, there's like a 1/3 reduction of death due to bleeding if you give this drug within the first 3 hours. And shortly after we got the results, we got the trial done at the time of the war in Afghanistan and Iraq, and the American military invited me to Washington to tell them about the results. And so I went to Arlington Cemetery and I took a picture of this graveyard, you know, these graves. Now, Arlington Cemetery is a really desperately sad place. There was at that time there were soldiers with guns firing salutes over dead soldiers. It was really sad. And but say there's about 100 graves in this picture. Had they been treated with tranexamic acid, the graveyard would look like that. That's a 1/3 reduction in death due to bleeding. That's big and noticeable and worth fighting for. So this is a really good treatment effect. Now, the big change in the UK, a big change that made a lot of people interested in intramuscular tranexamic acid, which I think is the really important thing at the moment, was the Manchester Arena bombing inquiry. So whenever there's a big disaster like this bombing, usually afterwards people start asking questions. Did we respond to it right? Is there anything we could have done better? Supposing something happens again, like this again, how should we do it differently? And what the inquiry recommended was that the kind of standard of care at the time was intravenous administration of tranexamic acid. Now, imagine you've got hundreds of patients. Well, getting a line in all of them really quickly, that takes time. It can be very difficult to get intravenous access in very shocked patients. And paramedics are supposed to give tranexamic acid by a slow intravenous injection over 10 minutes, and they hate that because 10 minutes seems like an eternity. And we were starting to show around that time that intramuscular tranexamic acid is very rapidly absorbed and well tolerated. And so the inquiry recommended that, intramuscular tranexamic acid could solve a lot of problems, or would solve a lot of problems, and they recommended it for the use in mass casualty events. And of course, how do you best prepare for a mass casualty event? Well, you do it in your everyday practice. So basically, what's the evidence that tranexamic acid is well absorbed after intramuscular injection? Well, we've done all of this pharmacokinetic work. So we first injected it into healthy volunteers, and then we found, whoa, fantastic. You get therapeutic levels. So the level in the blood necessary to inhibit this fibrinolysis, this chopping up of blood clots, is about 10 milligrams per liter. And with an intramuscular injection, you reach that in 3.5 minutes. Now, I can't put a cannula in 3.5 minutes. I mean, perhaps some of you can, but I'm still getting my stuff together in 3.5 minutes. So you get, a rapid intramuscular injection could be even better than intravenous injection in terms of getting therapeutic blood levels. So that's in healthy volunteers. Well, what about bleeding trauma patients? Well, we did a study in bleeding trauma patients at the Royal London Hospital and St. George's, and we got therapeutic levels in somewhere between 4 and 11 minutes. So that's really good again. You know, that's still pretty fast considering you're supposed to give the injection over 10 minutes. This study allowed us to look at, well, what's the effect of shock? You know, because sometimes shock, like you get this shunting of blood from certain places to somewhere else. That's why the skin is all cold and clammy in shock, because the blood vessels in the skin have been kind of constricted to move the blood to places where it's more important. But that doesn't seem to happen in muscles. And actually, we got very good. So the black line is shock present and the red line is shock absent. Well, actually, we got higher blood levels when shock was present. Now, that's probably because the absorption's not affected by shock, but the excretion is affected by shock. So tranexamic acid excreted by the kidneys. And if the kidneys are, you know, not filtering the blood very much because the blood pressure is so low, you get kind of a, you know, you get better blood levels with tranexamic acid in shocked patients. So it's all good. Intramuscular, and we look very carefully, you know, were they getting problems at the injection site? No problems at all. So it's all looking good. We've recently done another study in pregnant women, and we got exactly the same results, you know, therapeutic levels about 4 to 10 minutes. So we can be quite sure that intramuscular tranexamic acid is rapidly absorbed and well tolerated in bleeding trauma patients. And so now we've got lots of evidence that tranexamic acid is life-saving. We've got the CRASH-2 trial. That's the biggest trial. Then we did the CRASH-3 trial because people wanted to know what about isolated traumatic brain injury, and the effect was pretty much the same. And then they did these smaller trials in the US and Australia, but the results are essentially, they've got wide confidence intervals, but they're all pretty consistent. And when you add them all up together in this thing called a meta-analysis, you get a 20% reduction in death. And like, this is a p-value, and that's quite small. This isn't a fluke. So tranexamic acid is life-saving. You have to give it really quickly. And you can give it really quickly because you can just inject it into the muscle. So time is bleeding. I think that's what's going on, really. So in fact, in the olden days, in antiquity, they used to measure time as the flow of a liquid. This thing here is called a clepsydra, which is like they used to have sundials to start with, but you can't tell the time when the sun's not shining. So they used to have these pots. They used to fill them up with water, and it drains down, and then that's an hour. And then you take the one at the bottom and you fill it up to the top, and that drains down. It's another hour. Well, this is what's happening with bleeding, I think. That actually tranexamic acid prevents bleeding. Can't put the blood back, and bleeding happens really quickly. So time is bleeding. My next door neighbor is a potter, and I got him to make this. He kindly made this for me, like a sort of, it's like a clepsydra of blood. I got some fake blood, and I staged this in my back garden. But that's the main message. Time is bleeding. And if you want the same thing, but in a kind of fancy graph using the trial data, here it is. So this is the odds ratio for survival. So an odds ratio of greater than 1 means you've got a better chance of surviving. And so it's about a 70% better chance of survival if you give it really early, but it goes down quite steeply. So this is time here, chance of survival. There's a 10% reduction in the life-saving effectiveness for every 15-minute treatment delay. So, you know, there's absolutely no time to waste with tranexamic acid administration. And that's why I'm always so excited to talk to paramedics, because this is your drug. It has to be given pre-hospital. Pre-hospital is where it should be given. So road crash, fall from height, but also, very importantly, older adults who have, you know, falls in the home environment. They, you know, people don't realize that that's actually in the elderly, that's major trauma. They often do very badly. And in fact, we had some very interesting data. I did a study with a professor of pre-hospital care called Tim Nutbeam, and we got results that, I don't know, they kind of show that we're an element, well, not an element, some sex discrimination in the use of tranexamic acid. So this is the data. So basically, what we've got here is the ratio of women to, if the rate, this is the ratio of women getting tranexamic acid compared to men. If women are just as likely to get it as men, the ratio is 1. And this is the severity of bleeding along the bottom axis. And so if you've got data above the line, it means that females are more likely than males to be treated. But you can see it's all below the line, which means females are less likely than males to be treated. So in low risk patients, they've got a low chance of dying from bleeding. You know, the likelihood of getting tranexamic acid if you're a woman is about half. And even in the highest severity of bleeding, you're still substantially less likely to get tranexamic acid. And I think, well, I think it's because what we consider major trauma is kind of gendered. Like, so if we see a man in leathers and a helmet in a high-speed road crash, we think that's major trauma. But if an older person's fallen downstairs in the home, we don't think that's major trauma, and we're treating them differently. So this is the future. So intramuscular tranexamic acid. Companies now, there's several companies have concentrated tranexamic acid. So the dose that we used in the CRASH-2 trial and the CRASH-3 trial was 1 gram stat followed by 1 gram infusion over 8 hours. Now, I think the one that's doing the heavy lifting is the first one. It's actually, once you inhibit you've got to inhibit fibrinolysis in those early minutes. And so getting that first gram in quickly is really important. You can give another gram in hospital if you want to, but it's the first one that's the most important one. And so a gram of tractors, and these are coming soon. They should be on the market in a couple of years. So I think that's really exciting. Paramedics can still give intramuscular tranexamic acid now without an auto-injector, but I think auto-injectors are coming soon. Now, Ryan asked me to talk about the CRASH-4 trial. So this is a trial of pre-hospital intramuscular tranexamic acid in patients with mild traumatic brain injury. So this is why are we doing this trial? So briefly, we did a big trial called CRASH-3, and these are some results. So in severe TBI, there was a reduction in all-cause mortality at 24 hours. And tranexamic acid went into guidelines for moderate and severe, but not mild. And in mild TBI, there was actually a bigger, well, mild and moderate, there was actually quite a big treatment effect. So this is the thing, mild traumatic brain injury isn't mild in the elderly. So as you get older, like young people can tolerate mild traumatic brain injury, and they can, but as you get older, I think your brain shrinks a bit. So when you have a head injury, it sort of shakes around more. And so older adults are much more likely to get an intracranial bleed after a traumatic brain injury. So now we're giving intramuscular tranexamic acid or placebo to older adults who've got there's some reason to believe they've had a head injury, they've got a laceration, bruising, or something like that, but also some shaking of the brain, some impairment of consciousness, loss of consciousness, amnesia, confusion, vomiting. And it's mild TBI, which is a GCS of 13 or more. They've got to be within 3 hours of injury, and and they're being planned, and you're planning to take them to hospital. But this is a trial running in the UK at the moment. It's going really well. We've recruited 2,500 patients, and we've got another 2,500 to go. All of the well, I don't know all of them, but lots of major of ambulance services in the UK have signed up to this, and it's going really well. Now it's recruiting in hospitals as well as pre-hospital, but the pre-hospital recruitment is the key to this trial, because if you treat patients who get it from it by paramedics, patients who are treated by the paramedics are treated on average an hour sooner than those that we're seeing in hospital, where people present themselves to hospital after a mild TBI. So the mild TBI is a huge problem, and intracranial bleeding is the biggest threat. And so if we can reduce the risk of intracranial bleeding with a single injection of tranexamic acid, we might even be able to keep people out of hospital. And hospital overcrowding is a huge problem in the UK. So we're looking forward to that. And it's that's my leg. I wanted to know what it felt like, and it doesn't hurt. You can get 10 mils, 2 5 mil injections easily into the thigh or the buttock. But in actual fact, in the trial, most people are opting for the deltoid and aren't having any problem at all. So from a paramedic, I'm looking forward to the questions, but from a paramedic point of view, tranexamic acid is the only proven life-saving trauma treatment. All of the evidence suggests it's safe. And so the critical thing is to give a gram intramuscular or intravenously as soon as possible after the injury. And if we can do that, we'll save lots of lives worldwide. Thank you, Ryan. I'll stop there. Sorry about the interruption. I hope we've got plenty of time for questions. Yes, we have.
No, that's great. Thank you very much. Yeah, we've had loads of questions coming in, and thank you for going through that with us, especially as, like you say, we've got all the research for TXA and how it is the life-saving drug. It's probably a medication that, as paramedics and pre-hospital clinicians, we get quite excited about. It's fairly new to us. A lot of us are working off a PGD, which varies throughout the UK, which we might see questions as well. I'll just have a look at some of the questions. So if a patient is prescribed oral TXA, say for menstruation reasons, will it affect the usage of intramuscular or intravenous TXA?
I suppose if you've got a trauma victim, I mean, tranexamic acid is quite a common treatment for heavy menstrual bleeding. But now, if you get a trauma patient, you're not going to know really whether they're taking, and women take tranexamic acid for heavy menstrual bleeding, of course, only when they're menstruating. But in a trauma situation, you're not going to know. So I would just ignore it. The good thing about tranexamic acid, it's got something called a wide therapeutic range or therapeutic threshold. So basically, the distance between a therapeutic dose and a toxic dose is quite wide. So if someone's taking some tranexamic acid and you give them a bit more, you're not going to do them any harm. So I think practically, I would assume that, they're not taking tranexamic acid. If you've got an injured young woman, just don't overthink it. Just give her a gram of tranexamic acid like you'd give everybody else. That's what I would do.
Perfect. I'm not sure what dose people take for tranexamic acid for the menstruation, but it could be sort of similar as the aspirin. You get people that take a 75 milligram aspirin, and then as part of the ACS protocol, we'll still give.
Yeah, I think they take for heavy menstrual bleeding, they're taking a gram 3 times a day. They take quite a big dose, because when you take tranexamic acid orally, it's actually not very well absorbed. You lose half of it. Because it's very poorly absorbed from the gut. So it's only 50% bioavailable. So if you take a gram, you only get half a gram into the blood. So the oral dose is something like, I think it's a gram 3 times a day for heavy menstrual bleeding. But in a trauma case, I would just give a gram intravenously.
Perfect. And then we've got, is there a preference for intravenous versus intramuscular administration in hospital if first dose has not already been given pre-hospital? And are there any different outcomes based on the administration route?
No, I don't think there are any different outcomes. It's like what we're trying to prevent is um, in all of the trials, the outcome that tranexamic acid prevents is death due to bleeding. So um, a few people have said, well, maybe it has anti-inflammatory effects, but I think its main effect is it helps coagulation and stops people exsanguinating. And the main thing biologically is to get therapeutic levels. And we've shown you get therapeutic levels just as quick with an intramuscular as an intravenous. Obviously, if you've got a cannula already in, then maybe an intravenous, with intravenous injection, you get therapeutic levels quicker. But then you've got to give it slowly over 10 minutes. And a lot of people find that's a nuisance. So I think when we started this research, we thought, well, intravenous is the first line, and if you can't do that, do intramuscular. But now I think I've switched on that one, and I think intramuscular is actually quicker because it takes away all of that time of cannulation and slow injection, and also Tim Nutbeam, this professor of emergency medicine in the Southwest, he does a lot of work on people trapped in their vehicles, and often you can't get intravenous access, but you can usually find a bit of muscle that you can put an intramuscular injection into. So
Yeah.
I would make it for me, tranexamic acid is a pre-hospital intramuscular drug.
Perfect. And I think that leads on to the next question as well. So we've got any considerations for auto-injectors for TXA to become commonplace? Also, this may be more of a United States problem. Do you feel it would be appropriate to have EMT level providers administering TXA with the auto-injector for patients with significant bleeding or trauma with significant changes in mental status? Now, that's, I know I went and did some major incident training with Nauru, and the auto injectors, I believe, are coming. They've got the concentration down to 2 mil, so it
Mm,
can go into the auto injector.
mm.
And I think the plan is to have that rolled out as part of the major incident response. I know that the heart teams in the UK, they carry a little pouch which has just got loads of vials of TXA, no auto injectors yet. But that's my part on it, but I'll hand over to you.
No, that's really interesting. So yeah, I was at a meeting with the military about 3 weeks ago, and yeah, this is something that they're really trying to push forward really fast. But I think it's going to be. It definitely will put them into that. It will put tranexamic acid in the hands of EMT providers, level providers. Um, there's also people talking about, well, mountain rescue teams. Often police officers are the first at the scene of um, road traffic crashes, and so it could be made quite widely available because it's not a dangerous drug. You can't shoot it up, or you can't sell it on, but it's safe and effective, and even if you get it wrong, you're not doing any harm. So I think it could be quite widespread in the future.
Yeah, and I think TXA doesn't have to be a paramedic only drug. If it is via intramuscular, there's no reason why EMTs or other pre-hospital clinicians can't give it. Obviously, the PGDs have to be written and signed by each individual trust for that,
Yes.
but it's definitely something they can move forward to. And I know that in major incident from Manchester, they're looking at the auto-injector for TXA and they're looking at analgesia as well. They're saying that whilst sort and heart staff are moving through sort of the warm zones, they can be given IM TXA, a fentanyl lollipop, or IM morphine, depending on whichever route they go. So I think it will come.
Yeah, I think it's changing really quickly. It's exciting.
And is there any major concerns with TXA in conjunction with a query head injury, like a TBI?
Yeah. Well, okay, so I think there are these two scenarios that probably need to be separated, and sometimes they can be hard to separate. So somebody has say they have a thrombotic stroke, and then they fall down and hit their head. Um, Sometimes it can be difficult to know what came first. Did they fall and lose consciousness, or do they lose consciousness and fall? I think that can sometimes be difficult to discern, to tell which one from the other. There's no evidence that, like, well, it on biological grounds, it wouldn't be a good thing to give a dose of tranexamic acid to someone who had a thrombotic stroke. So, we should avoid that. I mean, some strokes are hemorrhagic, but the majority of them are thrombotic. So we wouldn't want to give tranexamic acid to someone who had a stroke. So that's what we've got to think about. Is this a head injury? Someone trips and falls, hits their head. That's a head injury. Car crash, all of that's very straightforward. But very occasionally there'll be this uncertainty about how this patient's lying on the floor and they've got a cut on their head, but did 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 they lose consciousness and hit the ground, or the other way around? So I think that can be a difficulty sometimes. What else? The other thing that can be difficult to tell is time from injury. So, you show up at, the ambulance shows up and there's somebody at the foot of the stairs, no witnesses. How long have they been there, and it's difficult to know. So tranexamic acid doesn't do any harm if you give it late. In the first trial, there was a suggestion that it might be harmful if you give it late, but as we've got more and more data, it doesn't look like that's the case. So if you get it wrong, it's not disastrous, but it's only really effective when given in the first 3 hours after injury. So, being sure about that time window is another challenge sometimes. So I think those are the main two.
Yeah, no, definitely. And as pre-hospital providers, we always get that with our stroke windows. Carers will go in the morning and see that patient symptomatic or at the bottom of the stairs, like you say. You just don't know, was it before they went to bed? Was it first thing in the morning? It could be anything from half hour to 12 hours potentially.
That's right.
But that's a good point. So the next question, I'm not sure so we like to use 1 gram of TXA via the MAD for unstoppable epistaxis in German EMS. Could the application via the MAD be a possible alternative application for the trauma patient instead of IM or IV? I'm not sure what
I'm
the
not sure what MAD is. Let's think what it could be.
if you
So
could drop it in the chat.
the main routes are MAD. I don't know what that is. I know it's the routes that I know about are intravenous, intramuscular, and intraosseous. But
There we go. Nasal atomizer.
Nasal atomizer.
Mucosal atomization device. Thank you very much for people digging us out.
All right. Okay. No is the answer. I can be very so when we started our work on trying to find alternative routes for tranexamic acid, we looked at all of these. We looked, will it work sublingual? Will it work intranasal? Will it work? And what we find is that it's very poorly absorbed through mucous membranes. So it's a very hydrophilic drug. That means it's a sort of like, it likes water, and actually your mucous membranes, your cells, are fat. So that's why it's poorly absorbed into the gut, but it's also poorly absorbed under the tongue or in the mouth or up the nose. So it's not really, it's not going to work. The two routes that you get therapeutic levels quickly, and that's what you need in trauma, are intravenous and intramuscular. So I don't think intranasal or nebulized or whatever it is going to be good enough for trauma.
Perfect, thank you. And then we have guidelines that state the max dose for intramuscular injection is in the rectus femoris and two other sites at only 5 mil. We can only give 10 mil IO or IV. So I'm guessing they're saying that their local procedures prohibits them from giving such a large IM injection.
Yeah, well, I think the maximum dose is 5 mils, but you have to divide the 10 mils into two 5 mil injections. So you give two 5 mil injections, different different muscles, and we're doing that in our we're doing a big obstetric bleeding study, and I was we're doing it. I was in Pakistan last week because we're recruiting lots of patients there because women die of postpartum hemorrhage much more commonly there, and we give two intramuscular injections of 5 mil intramuscular injections, and then you can do it really quickly and they're well tolerated. So that's the solution to the 10 mil problem. But of course, as Ryan says, the tranexamic acid is now being concentrated, and as long as that doesn't have any, as long as that works, doesn't have any, there aren't any problems with that, then that will be a big step forward.
No, perfect. So I'll go through nice and quickly. We've got if previous paramedics, or if previously paramedics administered TXA due to it being an intravenous drug, does that mean that technicians would be able to administer TXA via the IM route? Now, I would say it's at the moment under a PGD. If you've not signed that PGD in the UK, you cannot give that drug. And at the moment, it's paramedics only. But as we start to get the research in, I don't see why it wouldn't be an EMT drug. Would you agree?
Well, yeah, I'm glad you answered that because it's more of a kind of regulatory. Everybody has to follow their rules that they're that govern their practice, and so it's a question of whether you're allowed to do it or not. But I'm sure um, technicians would be able to give an intramuscular dose, and that's the hope that we actually we kind of take tranexamic acid out of the hospital to where people are being injured and into the hands of whoever's caring for them, immediately after injury. And if that's emergency medical technicians, then that's what we need. Yeah.
Yeah, and it will just stop that delay from if an EMT crew turn up, they can give the TXA rather than waiting another 10, 15 minutes maybe for the paramedic on the response vehicle, and then that just gets that TXA into the patient sooner, which
Absolutely.
then the patient wins then.
Mm.
We've had a question, what concentration of TXA is being carried on the front line sort of dual staffed ambulance? Now, a lot of people are putting there, I know east of England, we have 500 milligrams in 5 mil, and it's two vials drawn up into a 10 mil syringe, and then we give it as that over a minute. But I know some trusts throughout the UK, they have to go for 10 minutes, and we do a lot of training with sort of like Yorkshire, London ambulances, and as a paramedic, you work to your scope of practice. So whenever I'm on a training exercise, I'm always Mr. TXA because I can seem to give it quicker than other trusts around the UK, and then they can give ketamine and other drugs. But
Mm.
I think the general consensus is 500 milligrams in 5 mil.
That's yeah. Most of the formulation is 100 milligrams per mil, so that's right. That's the only formulation I know in the UK.
Or we've got Yorkshire can get they've got 1 gram in 10 mil, so they've got a 10 mil vial. Apparently, London Ambulance Service as well have that.
Oh, I didn't know that. I didn't know there was a 10 mil vial. That's interesting.
Yeah, and Northwest have got it as well.
Oh, that's great. That's good. That's much more convenient. Just one vial. Yeah.
Yeah. rather than dropping it at the side of a road. I know in our drugs bags we only have 2 vials, so if you drop one, you're knackered.
But just give the other one.
Yeah, give them something.
Give them something.
Yeah. So we've got, could the introduction of auto-injectors facilitate the rollout to first responders, including police, traffic officers, CFRs, non-medic soldiers on the battlefield? I think we've covered that one. I think that's where it could go if you've got the auto-injectors.
I think it could, and there's some legal thing. I think it's is it section 19 or something like that? You might know more about this, Ryan, but there's certain drugs that people like mountain rescue people and police officers can give. You have to be on this. I don't know the number of the section, but Tim Nutbeam is looking into that and you've got to get the government to approve it or something like that. So people are looking into getting tranexamic acid on this whatever section it is, so that that can happen.
Yes, I think you're right with that. And if the drug isn't on that, that's where each individual trust will write a PGD that will circulate to the staff that you sign individually, and then they're the sort of set. You can give it in this instance. These are your contraindications, these are your indications, and this is your route of administration. So if
Yeah,
it gets put onto the that law, I think it could be section 19 or 29 or something like that. But once it's on there, you kind of you don't get creative license, but it's easier for allowing
that's right.
other disciplinaries to use it. Next, we've got, why is TXA often contraindicated in bleeding that started more than 3 hours prior? Is there an associated increase in poor outcomes if we give it after the 3 hours?
Well, it comes from the CRASH-2 trial, because in the CRASH-2 trial we had an overall reduction. So the initial eligibility criteria, you could give tranexamic acid up to 8 hours of the injury. And we pre-specified that we would do a subgroup analysis of less than 3 hours, more than 3 hours. And in that analysis, we saw all of the benefit was less than 3 hours, and there was no benefit after 3 hours. There was a suggestion that there was more bleeding if you give it late. But as I mentioned before, the more we've looked at that, because we did another big trial, and there's been other big trials. So as more data has accumulated, the benefit of giving it less than 3 hours has got more certain, and we can't find any evidence of harm after 3 hours. So I think probably the answer is no, it's not harmful if you give it late. Obviously, you can't be 100% sure. But the point is that if it's not effective, no one's benefiting. So, and we can be quite sure that its effectiveness decreases really rapidly. And so after about 3 hours, there's not much benefit at all.
Perfect. And then we've got, is there any research suggesting can it be given quicker than 10 minutes intravenous, or does this come with implications?
Oh, I wish I knew that. So, like, I've been trying to get to the bottom of this slow intravenous injection thing. Where did it come from? And the closest I've got is the tranexamic acid is an old, it's been marketed for a long time. And the original license holder was Pfizer. And when Pfizer made an application to the FDA, so I managed to get hold of those documents. And in those documents, they did studies on healthy volunteers, and one or two of the patients who got a very rapid dose felt a bit queasy. And that's it. I can't find any evidence of hypotension, but somebody felt a bit sick. And after that, it goes into the summary of product characteristics. And once something's there, it's almost like it can never be taken out. But I don't know. I can't find any evidence that it causes hypotension. I really can't. I'd like to it'd be nice to do a study where you actually put people on blood pressure monitors and then give it quickly and give it slowly. But because it is a nuisance, this slow intravenous injection, and it might not be necessary at all. Because like it just says it in the summary of product characteristics, but I can't find any evidence for it. So I suppose the answer to that question is I don't really know.
No, and I think the only thing I've seen is a bit of nausea from when I've seen it given quickly, normally by the local HEMS teams. They'll just turn up and give it straight away. And the only side effect I've seen is someone vomiting. That's
Yeah,
pretty.
I think it does cause nausea if you give it really quickly. I think what I this is just my hypothesis is that the nausea is a central effect, and the central effect is a product of the peak dose. And so if you get it really quick, you get a high peak, and so people feel transiently a little bit sick. Um, I've seen lots of doctors give it quickly, and it doesn't seem to cause any problems.
No, perfect. And then we've got, can you speak to the 2 gram IV push dosing that the US military have adopted? Is there an advantage of going for the 2 grams over the 1 gram when using IV dosing?
Yeah, so there was one small trial in the US where they compared 1 gram, 2 grams, 1 gram or 2 grams or placebo. And I didn't think there was very compelling evidence of benefit of 2 grams over 1 gram. In my opinion, there's no benefit. Um, but that's what they concluded. Um, in a way, I think it's not that. I don't think it's such a big deal. It doesn't matter to me enough to be really worried about it, whether it's 1 gram or 2 gram. The most important thing is that it's some and early. So I put the most important thing with tranexamic acid is time to treatment. If you give 1 gram or 2 grams, I don't think it's not a big deal. I think you inhibit fibrinolysis with 1 gram. You also inhibit fibrinolysis with 2 grams. I don't think it's a big deal. So I don't think there's any, to me, there doesn't seem any big advantage. But if it's in the guideline, then just follow the guideline. But it doesn't really matter, I think.
No, perfect. And I suppose it's the 1 gram's going to work, so we'll stick to that until told otherwise.
Yeah.
Um, so with regards to silver trauma, so our elderly patient falling downstairs, often they're frail with not much muscle mass. Is there a weight limit of when we should be using a lower dose?
Well, actually, in our older adults study, in the CRASH-4 trial, we're using 500 milligrams, and we did that because of this reason. Sometimes people are frailer, they're smaller, and also their renal function is sometimes less. And only time will tell. I don't know what the results are going to be of the CRASH-4 trial, but I think it's quite safe to use a 1 gram dose. Um, um, so at the moment, I don't know. I don't think one gram is too much for them. If you worry, if they're really skinny and you're worried about 5 mils in one deltoid, break it up into two. Break it up into more pieces, and you can give 4 injections if necessary. But I don't know really whether a lower dose is going to be equally effective, and that's partly it's going to be one of the answers from the CRASH-4 trial.
No, perfect. Thank you very much. And then we've got, does TXA supersede any anticoagulant therapy the patient's already on? So do they cancel each other out? Just thinking about the silver trauma.
Well, in our CRASH-4 trial, we've got a lot of patients on anticoagulants and antiplatelets. So as you get older, of course, you're more likely to be on an anticoagulant because you've got some, atrial fibrillation or something like this. But they're the patients, I think, who are more likely to benefit from tranexamic acid because they bleed so much more easily. So injured patients on antithrombotic or antiplatelet drugs, I think they're exactly the sort of patients we should be treating because those are the patients who can have the big dangerous bleeds. So it doesn't sort of it's a completely different mechanism of action. It won't reverse the effects of those drugs, but hopefully it will, whatever clot they do form, it will protect it. And so because they can form less clot, it needs more protection in a way.
No, perfect. I suppose it's all about stabilizing that clot that they're going to have if, well, like you say, whatever clot they've got needs to be stabilized with TXA.
That's right.
Uh, so just moving back to the intranasal route, is that still effective for epistaxis? So if we give it intranasal, essentially sort of like a topical way of giving it. Someone's also mentioned if we give it nebulized for upper airway bleeding. Is that still, do you have any sort of research on whether that's still effective?
The compared to tranexamic acid in trauma, surgery, and postpartum hemorrhage, the volume of research evidence on epistaxis and um, what was the other one you mentioned? Epistaxis and
Upper airway bleeding.
oh, upper airway bleeding. There have been small trials of both, and it seems a little bit promising, but like there's much less evidence. So, like, if you're asking me to talk on the basis of evidence, I think there's not a lot to go on really. Um, you know, lots of people they soak swabs in tranexamic acid and put it up the nose for epistaxis. But I haven't seen big trials uh, of that. And so I think the evidence base is not as good. It's a bit of an unsatisfactory answer, but
No,
yeah.
that's perfect. No, that's fine. And we've got someone's just commented saying GR Calc stated that two 5 ml IM at separate sites. Yeah, so we just split the dose into two intramuscular sites. Then we've got why is gastrointestinal hemorrhage contraindicated for TXA? Also, would you advocate for TXA administration ASAP in any suspected traumatic cardiac arrest? Now, with the GI bleeding, I guess they're going down the form as GI bleeding normally presents hours, if not days, potentially, which goes down that whole losing
Yeah.
10%
Well, we
survival.
did we did do a big trial, like something like 13,000 patients of tranexamic acid in GI bleeding, and like I was really disappointed, but it didn't seem to have any effect. It didn't seem to have any big adverse effects, but it didn't have any benefit at all. And I think it was for the reason that you've just given, Ryan. Is like you just don't know when it starts a GI bleed. You know when people vomit blood, but that's not when they started bleeding. You know that these varices. You know when you get these esophageal varices, where they burst and you know they slowly glug and fill the stomach, and then the patient feels full of blood, and then there's a big hemoptysis. They could have been bleeding for hours before they vomited. So I think it's probably because you can't time the onset precisely.
No, perfect, yeah. And then going on to traumatic cardiac arrests. Now, it's mentioned within the JRCAP guidelines as part of when we talk about our HOT principles, hypovolemias, we're going to give our tranexamic acid. Um, all of the recent traumatic arrests I've done, tranexamic acid has been given. I'm not sure whether it does give any benefit from it. If they have it exsanguated, do they have any clots to protect? I don't know what your thoughts are on traumatic arrests.
Well, I have when you get a cardiac arrest, it's a really strong stimulus to fibrinolysis. So I have seen studies where um, where you measure fibrinolytic markers in patients with who have had a period of cardiac arrest, and they're so it's a little bit like the blood stops circulating, and then you've got this. The endothelium responds by putting out tissue plasminogen activators. It's almost like it's trying to keep the blood liquid because it's static for a while. So you get a big fibrinolytic burst after in cardiac arrest. And so if you do regain circulation and you are bleeding, then that's going to worsen bleeding. So I think you know. Traumatic cardiac arrest, it's trauma. I would give it.
Yeah, perfect. And it's in the guidelines, and I've always seen it given for traumatic arrests. Moving on quickly, we've got currently in Ireland, only advanced paramedics can give TXA. It's given as a 1 gram in 100 ml infusion. So I guess that hasn't been escalated down to the road paramedics or even EMTs. I guess they've got a little bit of a way to go. Did you know
Yeah,
that?
yeah. No, I hope it. I hope that happens. I think I'd like to see it in the hands of as many people as possible that are providing emergency care,
Yeah.
because the balance of risks and benefits is favorable, and it's difficult to cause harm with it. Japanese people, my wife's Japanese, and Japanese people take it for headache in Japan. So,
Okay.
my wife's, said, "Oh, I've got a headache," and she reaches for some tablets and takes one. And I said, "What are you taking that? What's that there?" She was taking a gram of tranexamic acid for headache, it's sold over the counter for that use in Japan. Um, Also, women take it in Japan to lighten their skin. It has this interesting, very slight dermatological effect that it lightens your skin if you take it consistently.
Okay.
So it's used as a treatment for melasma. These patches. These pigmented patches. Um, but anyway, I've gone off on a tangent. It's not a dangerous drug. Yeah,
Yeah, and I think for anything to be given to us pre-hospitally is normally really safe drugs, and we stick to our guidelines that we get given.
yeah.
I've got on here, can you speak to the results of the patch trial?
Yeah, the patch trial got essentially the same result. I'll show you very quickly the patch trial result because I think I had it in one of my slides. Let's go back. Oh, hang on. Why isn't it going back? Oh, well, I can't show it you. I tried to. For some reason, it wouldn't go back. But here we go. I've got it. You can't see it, but I can see it. So we found in the CRASH-2 trial, we found a 20% reduction in death within 24 hours with tranexamic acid. And in the patch trial, they found a 30% reduction. So the patch trial actually got a bigger reduction in death due to bleeding with tranexamic acid than we do. So the patch trial was a trial they conducted in Australia. When we got the CRASH-2 trial was in 40 countries, and we even had recruitment in Australia. But at the end of the trial, the Australians said, "Well, we do things differently in Australia, and so whether this result applies to Australians, goodness only knows." So they got a trial, then 10 years later they got a result which showed it's exactly the same as what we found in the CRASH-2 trial. So I was relieved about that I mean, if someone doesn't believe the results, I'd much rather them do a trial than not give it. At least half the patients are getting the drug. But eventually they came to the conclusion that tranexamic acid is safe and effective, and they put it in their guidelines too.
No. Perfect. Thank you very much. Is there any concern if we give intravenous TXA through the same line as blood, antibiotics, or any fluids?
Yeah, this is another thing on the summary of product characteristics. It says on the summary of product characteristics should not be given with penicillin or blood. Um, why, I don't know. I really don't know. So, I mean, the easiest thing is to try not to do that, but I wish I knew the why. As I mentioned before, things get on this summary of product characteristics, and once they're there, it's you you don't know why they're there, but once they're there, it's difficult to get them off.
Yeah, difficult to get them off that the guidance. And then
Mm.
someone's just added an inject. If we're worried about any nausea with giving TXA quicker, could we give some like an antiemetic before? They've said IV or IM on Danzatron. I'd say that's definitely an option. A lot of people do it before giving morphine.
Yeah, I think we could do that. I'm hoping, and this obstetric trial that we're doing now, that we're comparing intramuscular and intravenous. I'm hoping, but only the results will tell, that we'll get less nausea with intramuscular because actually intramuscular takes the peak off. You get a sort of, you inject tranexamic acid into the muscle and you get this kind of slower release into the blood. It's still rapidly gets, it still gets you to therapeutic levels really quickly, but you don't get the peak that you get with intravenous use. So I'm hoping, but only the results will tell. I've hoped for many things before that didn't come true, but I'm hoping we'll get less nausea with intramuscular. But I
Yeah,
mean, Ryan said that, he's had experiences when you give it really fast, intravenously, you get some nausea. And I've seen that in some obstetric trials. Um,
yeah, and I
but
think this was with a PPH as well.
That's right. So our latest trial should help to answer that question.
Perfect. And have you got any thoughts on TXA for ACE inhibitor angioedema?
Yes, it's supposed to be. This is a really interesting sort of biological mechanism, and it is a treatment for angioedema, and it's angioedema is like this. It's a it's a rather complex pathophysiology. It's something to do with complement and C3 and this and that, and the other. But plasmin is involved in that, and so tranexamic acid is an established treatment for angioedema. Um, so that's yeah, your knowledge is quite up to date on that one. The mechanism is really interesting. Obviously, it's a really rare thing, so there haven't been big trials, but it's standard of care for patients with angioedema. Oh, ACE inhibitor angioedema. Oh, that's different.
Yeah.
I don't know. I know even less about that.
Yeah, they've put sort of thoughts on TXA for ACE inhibitor angioedema. And what would the dosage in and route look like? It's not something I would know because
I
it's
haven't a
limited to
clue
trauma.
I haven't a clue what the answer to that question is. I just saw the angioedema part. One of these hereditary angioedema things that had something to do with C3 and complement. I don't know how ACE inhibitors cause angioedema. I don't know the answer to that question.
Okay, well, I'll do a bit of research and I'll put a post up on our social media
Yeah, that'd be interesting. I'd be interested the result of that one. Yeah.
just to see, just do a bit of research behind that because I'm not too sure. And then, is it okay to administer TXA for a major trauma patient who is elderly, even though there's no obvious signs of major hemorrhage?
I think so, yeah. In fact, the inclusion criteria for the CRASH-2 trial were with patients with or suspected to have, with or at risk of serious bleeding. So it was a very broad inclusion criteria. And so we had these patients who were, tachycardic and hypotensive, but we also had patients who had you know, a normal blood pressure and pulse, but they were still at risk of having, either an intracranial or a abdominal bleed or something like that. And actually, there was no evidence of harm, and it worked right across the board. The reduction in the risk of death was it was the same proportional reduction regardless of baseline. So if you had a patient, say, run over by a train, both legs severed, they might have a 30% chance of exsanguinating. With tranexamic acid, it reduced that to 20%. But if you had somebody fallen downstairs, they've got like a 0.3% risk of exsanguinating. Actually, with tranexamic acid, it reduces that from 0.3 to 0.2, the same proportional reduction. And of course, you get a lot of more patients with milder injuries than you get, there's more patients who fall downstairs than are run over by a train. So you get actually quite a lot of benefit at the mild end. So that's why with this CRASH-4 trial, and so we're actually moving towards the sort of milder, or so-called milder end of the spectrum, injury spectrum.
Yeah, perfect. I think that's when we jumped on a video call, we were talking about sort of the head injuries pre-hospital. We'll go out to elderly gentleman, female who's got a head injury, and then as soon as we see a Pixaban, warfarin, adoxaban on their prescription charts, we take them to hospital following the NICE guidelines, and they sit in a corridor for 3 to 4 hours before they even get a CT scan, potentially maybe even longer before they get off the back of the ambulance. And we're thinking if you could give IM TXA to them at the point of injury as we turn up, is that a better treatment than just watching them in hospital potentially?
I'm hoping this is what I'm hoping with the CRASH-4 trial is that at the moment, well, you described it very well. At the moment, patients are older patients. They're taken to hospital. When they get to hospital, it's too late to give them any treatment because they've passed the 3-hour window, and so they're taken to hospital, observed, and not treated. I hope that in future we could maybe patients could be treated and not observed because it's the if we could reduce the risk so we don't need to keep them in hospital and we could just give them an intramuscular tranexamic acid, leave them at home and say to the relatives, if there's any deterioration, just ring us up again. Something, that kind of thing. I think that's the future that I'm sort of imagining because the emergency department overcrowding is a big problem that the NHS has to solve.
Yeah, and a lot of these patients aren't for neurosurgery as well, are they? They're not going to meet criteria for going for sort of severe surgeries at these
Yeah,
specialist
it's
centres.
quite the risk of so we're finding in our trial that 10% have an intracranial bleed. A much smaller proportion have neurosurgery because mostly when they see these intracranial bleeds, they just don't do anything unless they're taking up a lot of space. But if we could reduce the risk with intramuscular tranexamic acid, then maybe we just observe them. I don't know.
No, that's great. And there's just a last one on there. Someone's put, is lisinopril a common home medication in the UK? Someone's commented on there as well. So yeah, I've seen it quite a lot given to patients that are
So
on it.
that's an angiotensin converting enzyme, isn't it?
Yes. Yeah.
Um, I don't know how common it is. I don't know the answer to that one. I think it's reasonably common. I think my father was on it, but I don't know more than that.
Yeah, I've seen it. I'd say it's a common medication. Then someone's just popped up when talking about that head injury. There is a local pathway in an area with head injury on anticoagulants to stay at home if they're unlikely to be scanned. I know that as a clinician, you can take that sort of holistic approach if you've got a dementia patient who is on anticoagulants, got a head injury. The
I see.
A&E department aren't going to want to put them into a CT scanner if they're going to have to sedate them or anything like that. They will just go down the monitoring route. If after 4 hours they're happy, they'll go home. So local pathways might be in place that you don't have to take anyone in. That's a good shout.
I see. I see. Yeah, interesting.
Maybe a more common sense approach, maybe.
Yeah, I can see the rationale.
And I think that is the end of all of the questions.
Well,
We're
thank
quite,
you.
yeah, that was really good.
Thank you to everybody for those really interesting questions that got me thinking. I have to look up ACE inhibitor angioedema and a few other questions there.